I know you need to get out of here. All right, guys, we're gonna get started with the iMCD session, and I'll go around and see if there's any stragglers out there. Okay, guys. So we are very lucky to have Dr. Sunita Nasta here. Sunita is an amazing clinician who's been taking care of Castleman's patients for many, many years, and she is just phenomenal. So I'm going to turn it over to her. She'll get into iMCD. If you are interested in unicentric Castleman disease, then there's a session down the hall. But I'll turn it over to Sunita. I'll go see if I find any other patients down the hall.
All right, sure.
Thanks, Sunita.
So I have a big mouth, but I think they are recording, so I'm going to try to use the microphone. If I blow your ears out, just, sorry. So I am a professor of clinical medicine at Penn, and tomorrow will be 25 years. Thank you. I don't really like to remember that number, but here we go. So I started taking care of Castleman's patients around then, and it's been an evolution of the management and the diagnosis, and we are learning so much about it thanks to a lot of you who have been part of the registry. So thank you all for joining and giving us the information that is helping us move this forward. I'm going to talk about idiopathic Castleman's, but I'm going to back up a little bit. I know David gave you a general introduction, but just so to make sure we're all on the same page. Okay. So when was Castleman's first identified? So Castleman first described this in the 1950s, and he did it purely by the pathology. Okay, you had people with enlarged lymph nodes, and they found these certain changes. I'll show you what that looks like under the microscope. But the constellation of symptoms that patients with Castleman's experienced was still not yet defined. It's still a relatively rare disease. It's what we would consider an orphan disease because less than 5,000 people are diagnosed in an average year. But people are living with the disorder, and so we need to understand more and more about the disease so that they live healthy, productive lives. So the pathology features, this is a busy slide. In the top two slides, we have what's called the hyaline vascular pathology. So now that everybody gets their path reports, you may see this, that hyaline vascular. What does that mean? It means that you have that onion skinning appearance. So you have these cells that are kind of clustered in rounds that look like onion skin, okay? And then below, you have the plasmacytic variant, which looks at the follicle of the lymph node, and there's infiltration in between those with these populations of plasma cells, okay? And these are different than the plasma cells that occur with multiple myeloma in that they're not clonal, meaning they don't come from a single cell. So we think that they are clustering there as a result of stimulation that brings them to the site. What we don't know yet is what is that stimulating factor? What is the driver behind these changes happening? So you guys who have been here before have seen these slides in terms of the development of the understanding of Castleman's disease and of the therapies that have been involved. So if you look at 1954, the first description of Castleman's disease, now we have newer entities in terms of unicentric Castleman's and oligocentric Castleman's that have helped us identify the different types of disease and how the treatment should be different for each of these groups. We first identified IL-6 back in 1986. We didn't know about it before then, and we'll talk about why that's important in a minute. But you can see that in particular, since about 2000, we've really had a more rapid development of treatment options because we are learning more and more about the constellation of symptoms, what might be some causative cytokines, and how we can manage them. Okay, so just to go through the overview, you're in the right room if you are on the right side of the slide, multicentric Castleman's disorder. And multicentric Castleman's disorder actually falls into three different categories. Okay, we have HHV8 associated multicentric Castleman's disease, which is a virally associated disorder that results as part of the constellation of symptoms that occur with the infection. And we have POEMS associated multicentric Castleman's disease, which is really a plasma cell disorder that has Castleman's associated with it. And in between, we have idiopathic multicentric Castleman's. So I had an old attending back when I was in medical school saying that idiopathic means that your doctor is an idiot because they haven't figured out what caused it. But we're not quite there. We're trying. And within idiopathic multicentric Castleman's, we have TAFRO and then not otherwise specified. So you can see at the bottom, this is a beautiful slide that Angela Dispensieri from the Mayo and David put together for a publication back in 2020 that shows how you have some that are hyaline vascular in pathology and some that are plasma cell in pathology. And that really helps us kind of target how the therapy should go. So you're familiar with the clinical presentation of Castleman's disease, and particularly idiopathic Castleman's disease presents with a global sense of a lack of well-being. Okay, people have fevers, they have enlargement of lymph nodes, they may have organ dysfunction, including liver function abnormalities, they can have kidney dysfunction, they can have symptoms of inflammation. Okay, and that can be mimicked in blood work that includes elevation of CRP, which is the best marker of disease with Castleman's disease, erythrocyte sedimentation rate, and fibrinogen, as well as effects on blood counts, including anemia, low platelet count, or changes in your immunoglobulins. And when you have TAFRO, you also can have fluid accumulation, which is generally represented by low albumin levels, which can cause edema in the extremities as well as the abdomen. And you need a approach that involves all of the people that may see you first. It might be a rheumatologist, it might be an infectious disease doctor, it might be your primary, and all of them have to work together to try to come up with why you are having these symptoms. And this is where things can fall down, because if you're not at a big center where all these people are in the same building or in the same room, it can take a while for people to kind of put the story together. So what are cytokines? I think that this is a question that a lot of people with the early diagnosis of Castleman's have. These are small proteins that have an important role in the immune system. They help stimulate immune cells. They regulate which immune cells need to be active at any particular time. And the levels of these vary from each of us day to day. And they produce cells in response to an immune stimulus. So say you have a strep infection, okay? You will get an elevation of IL-6 and TNF-alpha, and that will stimulate lymph nodes in your neck to enlarge so that they can fight the disease, okay? And they're supposed to regulate inflammation. There's a system of back and forth between those that increase inflammation and those that decrease inflammation, such that people can balance that inflammatory stimulus to last while the infection or the stimulus is active, and then to come back down to normal after. The problem with Castleman's disease is that these cytokines are not regulated. They remain elevated even without an infectious stimulus. And each cytokine can have multiple effects. Why is IL-6 important? So IL-6, you've probably heard about IL-6 a lot. Your doctor may have measured your IL-6 levels. Why is it so important? We know that IL-6 stimulates the development of Castleman lymph nodes and Castleman symptoms. So we know that it can go to the liver, and from the liver that produces increased fibrinogen. And when you have increased fibrinogen, your ESR goes up. We know that it causes a decrease in the normal albumin production. So even if you're eating right, even if you're getting the right amount of protein, you're not producing albumin, and so edema can collect. You can have decreased iron use, meaning we store iron in our liver and in our bone marrow. And so when you have elevated IL-6, your body doesn't know how to use that iron appropriately. So you can have anemia as a result. So you're acting like you're iron deficient even though you're not. And then it also produces CRP, and CRP, C-reactive protein, is an inflammatory protein. So when you have more of this, you have inflammation all over your body. So it's essentially like having the flu 100% of the time. So you've seen these diagnostic criteria for iMCD. What we need is some of the major criteria and then at least a few of the minor criteria to make the diagnosis. So when someone comes in and they say, well, I was told I have Castleman's disease, this is what we review. Do you have a pathology sample that looks like Castleman's disease? And that can be tricky because if a pathologist has not seen Castleman's pathology, they may not be appropriately able to diagnose it. And the concordance rate, meaning when we get a pathology slide, how many times it's concordant with what they're saying on the outside, and when we see at Penn, is about 1 in 3. So people can carry a diagnosis of Castleman's disease, or they can carry a diagnosis of IgG4, and then they get here and everything flips. Okay? And so it's super important to make sure that the pathology is evaluated at a center that sees a lot of Castleman's. Here, Arkansas, Mayo, to make sure that the appropriate diagnosis is made. Sometimes I have people come in and they say, I have a diagnosis of Castleman's, and I'm like, actually you don't. You have something else. And we do the evaluations that make that other diagnosis. And what you need to rule out is there an infection? Okay. Is there something else that is a driver of the Castleman's pathology? Because the lymph node of Castleman's disease is unlike a cancer lymph node, okay? So with a lymphoma, for example, or myeloma in the bone marrow, you have a cluster of clonal cells. These are not clonal. They are responding to something else. So if there is a driver that is something else, that is not Castleman's. That is a secondary Castleman-like change. So what you want to do is to target what is producing the symptoms. You can look completely like idiopathic multicentric Castleman's, but if you have one of these drivers, it may be more easily treated and put into remission. So it's important to make sure that you understand what these drivers are. Okay, so IL-6 targeted therapy. So you have the soluble IL-6. You can see that up here, okay? And it binds to the soluble IL-6 receptor that then comes and initiates signal transduction, which are signals within the cell that stimulate its activity, that can regulate its proliferation, it can regulate what cytokines it's releasing, it can regulate its activity. So when IL-6 is circulating in the body, it can go to the liver cell, to the hepatocyte, it binds to the IL-6 receptor and then goes and binds to this GP130 molecule that initiates signals to the nucleus. Okay, so how do the antibodies work? So when you're receiving Cytokine, which is here in blue, what it does is it binds the IL-6 directly. Okay, and this brings up an interesting point. When you have treatment with siltuximab and you measure your IL-6 levels, it's going to detect more. It's going to identify more in the blood. So I have patients who come in and they're like, my doctor checked my IL-6 level and it's through the roof. And I'm like, are you on siltuximab? Yes. And I was like, that's why. That doesn't reflect that you're not having a response. It reflects that the siltuximab is actually working because it's binding the IL-6. Okay. In contrast, tocilizumab, which is another IL-6 targeted antibody, that binds to the receptor. So it blocks the receptor from acting. Okay? So as a result, the receptor cannot bind IL-6, so it blocks the way that IL-6 can work. Yeah. Well, I'll explain why we start with one versus the other. Um, Actually, it's somewhat country dependent. In this country, we have studies that have proven an FDA approval for siltuximab. So that's the front line in this country. In Japan, the first studies were done on tocilizumab. We actually work with some Japanese colleagues who first used it, and so they tend to use more tocilizumab. They're about par, and sometimes we just are publishing. I think it's now published, right? Josh's paper on, yeah. So we looked at all of y'all's data, and there are patients who started on one and switched to the other, and had efficacy. So if it's not working, we switch to the other IL-6, and I think some of the people in the room have done that. All right. So how did we get to siltuximab being FDA approved? This was the design of the original trial by a company called Janssen who created siltuximab, and it looked at MCD participants who were symptomatic, had pathology that was confirmed, were HIV and HHV negative, and had never had treatment before. So they had the fevers, they had edema, they had symptoms of fatigue that could be attributed to their Castleman's disease, and they initiated by therapy with siltuximab, and they actually randomized to using a placebo versus siltuximab. And you're asking, Dr. Nasta, how could they have used a placebo? These people were sick. We had no other treatment for patients with Castleman's disease. So the FDA allowed for placebo to really be able to identify in whom the effect was actually happening, because as you know, people can have benefit just from getting supportive care. So we wanted to make sure that it was truly the effect of the siltuximab. So they did a 1-to-2 randomization, meaning one patient would get placebo and two patients would get siltuximab, and some of them were on steroids, and so we actually looked at the data for those who were on steroids and those who were off steroids. And they continued each of these until treatment failure. If you were randomized to the placebo arm, you were able to receive siltuximab after. So if you did a couple of months of the placebo and things weren't getting better, they would unblind and find out that you were getting nothing, and so then they would give you siltuximab. So what it really means is early siltuximab versus delayed siltuximab. All right, and that's how they were able to analyze. And the primary analysis was done at 48 weeks after the last patient enrolled. So the total number was the 26 who were on the placebo and the 53 who were receiving siltuximab. And that's not a large study, but if you think about the number of patients with confirmed Castleman's disease who could actually participate, this is one of the largest studies that have been done in this setting. So the primary endpoint was how long was the symptoms or the lymphadenopathy controlled. No one achieved a response with the placebo. That's no surprise, right? Like you're getting sugar water. And then in the arm that got siltuximab, 34% of the patients actually had a benefit. Their symptoms improved enough that they got back to normal function. And a smaller percentage actually achieved a complete response. Most of those patients had a partial response, and if they had a partial response, they would continue on therapy. And this was the progression-free survival. And what that means is how long they lasted until the symptoms recurred. So you can see that the placebo arm, patients quickly had recurrence of symptoms or progression of symptoms. And in the patients who stayed on siltuximab, they had significantly longer progression-free and overall survival. remember that the overall survival in the placebo arm is complicated by the fact that they eventually got siltuximab if they had failure. There was crossover. Okay, so this effect actually reflects them getting siltuximab. And then this has been repeated in real world studies, right? So not everyone can come to a single site to do a study. That's the problems that we've been having in terms of enrollment on our trials here. But these were real world studies once the FDA approved siltuximab, and it shows patients with similar overall response rates and complete response rates. Any questions before I go forward? Okay. All right. So we then looked at the data, and this looked at all of the patients who were treated by in the registry and by the people who treat Castlemans around the country. And this shows that if you're treated with either siltuximab or tocilizumab, your response is better than if you received rituximab alone or chemotherapy. Now, this is very specifically for patients with iMCD. And most of these patients did not have TAFRO. So you can see that receiving siltuximab or tocilizumab really made a big difference. So who is a good candidate for siltuximab? Not everybody is, okay? You need to have at least a few of the minor criteria to really show a benefit. And why is that the case? Remember that IL-6 stimulates the disease, but we don't know what the underlying driver is. So what we're basically doing is tamping down on symptoms, okay? It is a symptom management treatment. So as a result, the more symptoms you have, the more you're likely to benefit from the siltuximab. So sometimes when I have an asymptomatic patient with Castleman's disease, even if they have lymphadenopathy in multiple locations, if they're not having symptoms of the Castleman's, I don't necessarily initiate. Because as you know, or you may know, siltuximab is a treatment that's given over like a 3 to 4 hour period every 3 weeks, okay? So you're kind of tied to the clinic and coming in for infusions. So if you don't have symptoms, it may be worthwhile to wait until you do, okay? And continue to search for the driver of why you're having the Castleman pathology. So we now know that patients who are receiving siltuximab have improvement of all of those markers that you saw in those early slides, like all the things that I measure. Did the IL-6 respond? Did the VEGF respond? Did the CRP respond? All of these came down in patients with symptomatic disease. And that makes sense, right? If you're having symptoms and I give you something that manages the symptoms, you're going to feel better. So this is the current treatment algorithm for iMCD. And you noticed that like top of the list is to use these IL-6 antibodies as best possible. And you have to have careful management from there. If you don't have a good response, then you make changes. All right. You have to give the drug some time. So you're not going to take 1 month and then immediately come off. You have to give it some time. Okay. The situation of TAFRO is a little bit different. And if I have time, we can talk a little bit about how TAFRO is different than iMCD and OS. In those situations, because the cytokine storm is so aggressive, those patients tend to get ongoing therapy with agents like chemotherapy to decrease the driver of that hyperinflammation. The next few slides were provided by Dr. Van Ree, and it's a beautiful slide that talks about how the spectrum of iMCD should impact therapy. So people in the other room are talking about unicentric and oligocentric Castleman's disease. For those patients, they have few laboratory abnormalities. They're overall well. They might have some clinical symptoms, and usually they don't have inflammatory disease. Okay. In that setting, surgical resection of the disease can be very helpful for management. And the only reason you might consider other management is if you can't surgically resect. What we're talking about here is the multicentric varieties. And in those, you usually have moderate clinical symptoms and inflammatory disease, or TAFRA, which is very severe. And in those situations, treatment is absolutely necessary. Okay. Now, for those of you who have HHV8, multicentric Castleman's disease, because that is virally associated, the therapy is targeted to decreasing the reservoir of the virus. And in that situation, a monoclonal antibody with like rituximab can decrease the amount of the virus that's circulating and manage the disease. That is different than idiopathic, because idiopathic, we don't yet know what the driver is. And so we're kind of treating around it. We're trying to treat the symptoms and the presentation of the disease rather than exactly what causes it. Trying to get to that cause, that's what all the research is about. All right, so asymptomatic multicentric Castleman's disease. This is a very nice paper out of China that looked at patients who were treated with symptoms and without symptoms. And chemotherapy really didn't improve the outcome. All right. So in those situations, it may be worthwhile to wait on symptoms, wait on treatment, because you can tend to do better. And by treating with chemotherapy, it may open you to alternative issues like transformation or selection of a clonal disease like lymphoma or multiple myeloma. So chemotherapy is not necessarily the answer. So when you have TAFRO, which is the really severe version of iMCD, that includes low platelets, a lot of edema, fevers, renal dysfunction, and reticulin fibrosis in the bone marrow, as well as swelling of the liver and spleen. These patients need a combination of anti-IL-6 antibodies and probably something else. About half the time, the IL-6 antibody may be enough, but the other half need additional therapy, chemo usually. Once the severe inflammation is down, then you can go back to the antibody alone. For the idiopathic plasmacytic lymphadenopathy, this is a newer entity. These patients have elevated gamma globulins as their manifestation of inflammation, and as a result, their platelets are very, very high. And these patients respond beautifully to IL-6. Almost everybody responds, okay? And then with NOS, if you have symptoms of inflammation, then IL-6 antibody therapy can help, okay? So you can see there's a range of responses. And so not everybody is going to get the same therapy. And you've probably noticed that in your talking to people at various tables. As you circle around, everybody's gotten something a little bit different. So should we only use IL-6, and how should we use it? Well, what we know is we should use this for patients who have symptoms. And up to this point, the data has been for chronic dosing, okay? And so in patients who have chronic dosing, chronic symptoms, like patients with the iMCD, they get chronic dosing of the anti-IL-6 therapy. So every 3 weeks, you're in clinic for your siltuximab, or every 2 weeks, you're in clinic for your toci. In patients who have cytokine storm or who have macrophage activation syndrome as a result of therapies like CAR T, or if their cancer is initiating a cytokine storm, That's when rapid dosing, like every week, may be helpful to kind of get that cytokine storm under control. We still don't know the best route and how long we need to continue the chronic dosing. We've all been a little afraid in our symptomatic patients to decrease IL-6 administration because we don't want people to have symptoms again. So it's an ongoing issue in terms of how long do we continue. Why does it fail? It doesn't work in everybody. It doesn't work in everybody forever. And in those situations, usually it's because they have more IL-6 than the ciltuximab or tocilizumab can block. Okay? And that can develop over time. Because we don't know the driver, we can't affect the primary cells. And these cells are smart. They're learning how to release more IL-6. And so the time to steady state can be difficult, and sometimes patients have more disease than can be neutralized by the standard dosing. And we have other active pathways, right? We know IL-6 is one of the ways that Castleman's disease symptoms or inflammation is being stimulated, but we have learned through the registry and studies of all of the pathways that are in our patient cells, that there are other active pathways. And so the subsequent work, the subsequent research is how to target those pathways. And these are all the papers that have been published, look from the registry patients as well as larger registries, larger databases like Mayo, where we can look at various ways of targeting patients with Castleman's disease. That includes looking at the mTOR pathway. That's why we did this sirolimus trial that was open last year. I think we talked about that. And why we've opened the next phase, which is a JAK-STAT inhibitor using ruxolitinib. Because if you target an activated pathway, maybe we can stop the inflammation from starting. So this is the result of the 26 patients treated with sirolimus in the relapse setting, meaning they've gotten ciltuximab or tocilizumab before, and they're given sirolimus. And you can see that at the 3-month mark, we had some response, but this continued to improve. And at best response, we had a significant number of patients who had at least stable disease and some who actually achieved a complete response. There were only 2 patients with very severe disease on this trial, but patients with iMCD NOS did have some nice responses, and on trial, and patients treated both on and off trial have had benefit. This is a report of a patient who had Tafro in whom the standard regimens were not working, okay? And they treated them with ruxolitinib. And you can see how the treatment with ruxolitinib caused these lymph nodes that were Castleman's related shrink, okay? And this was after 8 months of therapy. So this gave us an idea that ruxolitinib might work in patients with relapsed multicentric Castleman's disease, even its most severe form. So this is a trial we currently have open. We have enrolled 2 patients on the trial. Funding is an issue, so our Quest for a Cure a few weeks ago actually raised money for this. We're currently looking to use ruxolitinib for up to a year in patients, and if we can prove that it's effective, that might help us talk to the FDA about providing it for patients, or providing the indication for patients with Castleman's disease. It is significantly easier than having to do an infusion every 3 weeks. It's not without side effects, but it allows people to live a normal life because they're taking a pill. And it's actually one of the drugs that was repurposed by David with the Every Cure platform to see if we could use it in Castleman's disease. Myelofibrosis, essential thrombocythemia, and polycythemia, those all have IL-6 dependent mechanisms and JAK-STAT activation. So since we knew that that worked in those settings, it made sense. So what do we do? This is looking to the future. Okay, so right now, asymptomatic patients would be observed. If you're minimally symptomatic, it might be a good idea to initiate therapy with an IL-6 inhibitor. If you have IPL, usually you're symptomatic, predominantly with pulmonary disease. Those patients would get siltuximab or toci in the front line in combination with steroids. If that failed, rituximab is used, but the majority of patients, up to 90%, respond to IL-6 inhibition. And then in the third line, you can consider new JAK-STAT inhibitors like ruxolitinib. For Tafro, the IL-6 inhibitors are usually given in combination with steroids. If that doesn't work quickly enough, meaning within a week, you would add Rituxan and chemotherapy, and then consider either JAK-STAT inhibitors or sirolimus. And if you don't have the antibody available, so for example, if you're in a very remote site where you can get IV chemotherapy or oral chemotherapy, but you can't get the monoclonal antibodies, then you could use some of these agents that have been used in plasma cell disorders, including thalidomide, cyclophosphamide, and prednisone, or bortezomib, cyclophosphamide, and dexamethasone. Do you need me? Yeah. And further research is going on with all of these different agents. And if you are offered a clinical trial, please consider participation, even to assess whether you're eligible, because it's such a rare disease. Getting people on trials is super important to really learning about it, as well as getting to that FDA approval. All right, so quickly, living with Castleman's disease, what to expect. Most people with iMCD, NOS, and even iMCD, Tafro, and IPL do well, okay, which is good to know. It's not everybody's experience, and there are some people who have had organ issues as a result of their disease that complicate their lives ongoing, but for most people, we do well. But as you know, it's not benign. You're constantly anxious about what's going to happen next. You're worried about the side effects of the treatment. You worry about what's going to happen in the future. Will I flare? Will I need the ICU? Your family bears the burden of you having Castleman's disease. And it's hard to feel normal, right? Your symptoms may be better, but you're not normal, right? You're going into the doctor all the time. You have to take time off from work. You may not feel up to work. You may need to be on disability. All of those things impact you from a psychological standpoint. For younger patients, there's questions about fertility. And then, can my disease transform into cancer? There are patients who develop a secondary cancer as a result of having iMCD, usually lymphoma or multiple myeloma. And so that's why, even if you're doing well from a symptom perspective, you need to stay in touch with your Castleman's doc, because they're usually either a lymphoma or myeloma doc who can make sure that you're monitoring appropriately. So if you're someone with a new diagnosis of Castleman's disease, I'm sure you've been through this. Locate a center that can treat Castleman's disease, learn about it. Go onto the CDCN website, monitor your symptoms, track your labs. If you have an electronic medical record, it can graph it for you. Do those healthy things. Eat well, try to exercise. Consider alternative therapies that keep you healthy, and then seek support. I think that that's probably the most important thing on this list. Watch for fevers, chills, night sweats, poor appetite. weight loss. Like everyone was like, oh my God, Dr. Nasta, I just want to lose weight. Like, no, you don't want to lose it this way. Okay. Um, you need to watch for 10% of your baseline body weight. If you're losing 10% without trying, you need to talk to your doctor. And then really think about what might be treatment related and what might be, Castleman's related. Sometimes you're immune suppressed as a result of being on siltuximab or on chemotherapy. And if it's an infection, you need to go in and get evaluated. And you can't do that on your own. So close contact is important. Is it important to monitor your labs? Yes, but obsessing about it is probably not the best thing. Look at it intermittently, and discuss it with your doctor about what each of these lab tests mean. They mean nothing to you if they're just the alphabet soup on the page. Why is this elevated? Is there something I can do about that? Maybe I'm also iron deficient. Maybe I also have some other issue that might be causing this lab abnormality, and it's important to manage that. And these are the lab markers to watch for: your hemoglobin, your C-reactive protein, which is probably the most sensitive measure of inflammation, your platelet count, and kidney function. What effects? Well, you know that those who are on steroids can have weight gain. You can get that Cushingoid moon phase. You're irritable. You have high blood sugar. Sometimes you have a lot of energy. You want to vacuum at 2 a.m. Might have edema, stomach irritation. With rituximab, you can get infusion reactions and low antibody levels, so you're at risk for infection. With the IL-6 antibodies, you can also get infusion reactions, but it can also make changes in your lipids. You have to follow your cholesterol. You have to follow liver function tests, watch your platelet count, look for infection. And the chemotherapy side effects can be myriad, okay? Your doctor can tell you what to expect, but for each patient, that could be different. And it's hard to know exactly what is treatment related and what is Castleman's related. That's not your job. If you're having the symptom, report it so that your doctor and you can discuss which one is which. Okay. Make sure that you're getting the appropriate symptom management. Look for anti-nausea medications, use your antivirals to prevent shingles, make sure you're taking antacids to protect your stomach from steroids, and talk to your doctors. Make sure that you have a healthy routine. Okay, so even if you're home, even if you're on disability, try to get onto a schedule every day of doing something, because if you allow that to persist, you may not be able to get going when you are feeling better. So maintain a schedule. Try to exercise every day. Make sure your meals are on time. Keep onto a schedule of what you need to do. What do we know about MCD and UCD in pregnancy? Not much. So in this situation, it's a conversation with you and your doctor, okay, about when you might be able to stop therapy and take a break. This is the other reason why, if you have asymptomatic Castleman's disease, it might be worthwhile to not go forward with therapy to allow you to live the rest of your life around the disease. What we know about autoimmune diseases is pregnancy can frequently make the symptoms of the autoimmune disease better. We have not had enough data to tell us what happens in pregnancy. Antibodies cross the placental barrier, so when you're pregnant, you cannot continue on antibodies because we don't know the impact on baby. So it is a discussion. But you can't stop moving. Keep moving forward, and we're learning more and more every day. So, we talked about 1954 to now. We have so much more than even when I started my career 25 years ago. So the future is bright. All right. There's some slides, but we have very little time. So I wanted to leave a few minutes for questions if you have them. What is gene rearrangement?
Yes, like
Meaning,
when you're reading like a pathology report, it says
right.
like clonal gene rearrangement. What is that?
So generally, patients with Castleman's disease do not have gene rearrangements. That's what defines a clonal disorder. Okay, so if someone has a lymphoma, they might have gene rearrangements. For example, patients with CLL, we look at immunoglobulin gene rearrangements to determine if someone has a mutated disease or an unmutated disease. Okay, so gene rearrangements, we're trying to find if there are any consistent ones in Castleman's. We haven't found that yet.
Somebody doesn't respond to sulfaximab, but they do respond to rituximab, but they're HHV8 negative, does that suggest there might be a virus involved?
Not necessarily, but I think it'd be important to keep looking. So it'd be worthwhile to just check for EBV in particular, as well as some of the other herpes viruses, CMV in particular as well.
I had a question.
Yeah.
About patients with Tafro and having like the really aggressive inflammation and such. As there are a couple of readings on like the JCI, like the investigative journals and stuff like that, for Tafro patients who are not going to be in like the phase 2 pill treatments and such. Are there readings that will be available for like how it progresses for patients who do have Tafro who got approved?
So, in the hospital, we can generally get treatment with ruxolitinib initiated if you have like this macrophage activation syndrome that Tafro is characterized by. It's a matter of whether you'd be able to continue it as an outpatient. Usually, patients with Tafro, you get treated with your IL-6 antibody, your inflammation is controlled with chemo, and then you should be able to continue with IL-6 after. In that setting, you would have to fail the IL-6, and then you can either go on trial to get ruxolitinib, or you can try to get ruxolitinib on a compassionate basis. There are patients who were treated and were able to get it, in that compassionate basis, and that was the report that I showed you with the 2 PET scans.
I had one more question.
Yeah.
About Tafro patients having like the higher likelihood of developing other specific cancers that like, for example, like you had originally gone with the diagnosis of lymphoma, of that coming back after like a certain amount of treatment. Would getting treated for like a cancer that is not Castleman's disease affect being able to get treated for Castleman's disease if there's not like a specific trigger?
So then the malignancy is the trigger. So if you have lymphoma, you have Castleman-like changes in your bone, in your lymph node, but you don't have you don't have idiopathic Castleman's disease, even if you have a Tafro-like syndrome. Then it's more lymphoma with macrophage activation. That's when we know what the driver is.